highlighted in our first session, what is the impact on health? What do we understand about that? And Samira gave us some wonderful examples from her own life, her own family, as well as from the work she's doing in the European Parliament. So we understand that there is a direct link between that level of discrimination and the health outcomes, physical and mental, that our next speakers will help us to understand that better. And I'm going to first of all introduce an online speaker. So we have Abhi Deivanayagam, who is the Academical Clinical Fellow in Public Health, Race and Equity at the University College of London. And we also have here, who will be in the room, Luna Ali from the European Public Health Alliance. But first, let me connect in with Abhi. Hello, Abhi. Can you hear us?
Yes, I can hear you. Can everyone hear me?
Yes, we can hear you and we can see you. So thank you very much for joining us. And I hope you had a chance to listen to the opening messages. You're going to share with us some perspectives, particularly because, of course, there was a 2022 Lancet series on racism, xenophobia, discrimination and health. So you're going to give us a summary. What were the main findings that made that direct relationship between the experience of discrimination, racism, and individual health? So Abhi, I'm going to pass the floor to you.
Thank you so much. I'll just wait for my slides to come up. Yeah, I can see them. Okay. All right, good morning, everyone. There's nothing that I'm going to say today that's particularly groundbreaking, nothing extraordinary, nothing that's revolutionary. I'm a public health doctor, a researcher, and a campaigner for climate, health, and racial justice in the UK. And I'm part of a research group at UCL called Race and Health that just published a series of papers about 8 months ago in the Lancet. And that was 2 years in the making about this topic. If we go to the next slide, we asked an OpenAI platform to write a speech on racism and health. If you just click on the so we asked, and if you look at it, it's actually really good. It's very, very good speech. And this is because Black people, Indigenous people, minoritized people, this has been said for years, for decades, for centuries. And in our series, we are building on this work. We're building on the work whose work that has come before us. Audre Lorde, Frantz Fanon, Angela Davis, Yin Paredes. And there are injustices in whose knowledge is heard. That's why for so long, racism and discrimination have not been mainstream public health issues. That's why when we talk about Black women in the UK being 5 times at higher risk of dying in childbirth than white women, we're asked, is it a biological reason? Are their bodies somehow different? Racism kills, and the diagnosis is beyond the individual level. And often at Race and Health, we give the example that if we all woke up tomorrow morning and we were no longer racist, the world would still be racist. And that's because it's in our systems and structures. It's not personal. Racism operates to protect the rights and power of those at the top of this created hierarchy, whilst placing those towards the lower rungs in closer proximity to death. Also in mainstream, racism can often be reduced to microaggressions or racial undertones. And we can waste a lot of time arguing about technique. And this is what racism does. It is all racism. It distracts us from tackling it. Next slide, please. So at Race and Health, we use the word minoritized instead of ethnic minority or any other categorization. Why? Because racial categorizations are often passive, they're imprecise, they don't cross borders very well, and they can lump several groups together. Whereas minoritized refers to an active process that erodes people's power based on the identity that's given to them by society. Next slide, please. So at the heart of our work is our conceptual model. And I'll take you through each level of this model, starting at the individual level. And it's often easier to think about racism at the individual level. We can understand prejudiced beliefs or unconscious biases against certain people. And sometimes we think that racism, it's over there, it's a community problem where Black people have been killed by the police, but it's not quite over here. It's a problem for those communities. But the evidence is global from our series. Discrimination is everywhere. And instead of us thinking of it as just one or two rotten apples. We need to think of it as a system that is rotten to the core. And that's where in the core we have structural discrimination. It's easier, it's difficult to grasp structural racism and discrimination, but we hope that our model tries to make the intangible more tangible and things that are invisible so often more visible. And at the center, I said we have these two concepts. So the first is separation, where humans see ourselves as separate to other humans or other species or other ecosystems even. And the second is hierarchical power. And in society, we have different hierarchies. And at the top of these ladders, people are given more privilege, therefore they experience better health and less good health for people at the bottom of these ladders. But these ladders have not merely just appeared, they've been created. And the hierarchy that we have historically continues to place white Europeans most frequently at the top of the ladder. Colonialism, we know, used hierarchies, and there have been racist laws and policies throughout time, the most recent one being apartheid, and the current one being apartheid, as someone mentioned earlier today, with what's going on in the Middle East. And academia, science, healthcare workers themselves have propped up these ladders. So why are we shocked when we have reports finding that health systems are institutionally racist? Modern health systems were founded as part of colonialism. And today, these health systems remain hostile and can cause harm. So for example, in the UK's NHS, health workers are told to question people's migratory status up front, and migrants who are ineligible can be charged or denied care. And this is where doctors are asked to be border controllers. And another example is our collective failure to distribute COVID-19 vaccines globally during the pandemic. And such events are a reflection of the fact that racism kills. And we know that racism also actively places minoritized people in closer proximity to things like air pollution and toxic waste. So that's this spatial determination level. And at Race and Health, we study categories related to caste, skin color, race, ethnicity, migratory status, and a few others. But in the real world, there are so many more ladders than that, such as gender, disability, class, many ladders, many hierarchies. And that's how intersectionality cuts across our society. It compounds these injustices. In the next slide, I'm going to show you how, so we've talked about how discrimination follows a path from the structural to the individual level. Those are the inputs. Now I'm going to talk about the processes. How do we process these things? And evidence shows that we have three main ways that we do this, and it can happen all at once. First, we respond through our behavior, so how we sleep, eat, move, who we spend our time with. Secondly, we respond psychologically, so how we internalize some of these ladders. And thirdly, we respond through our physiology. So a bit more on this. Our body perceives discrimination as stress, and it activates our fight and flight response. So our cortisol, our stress hormone level, goes up, adrenaline goes up, heart rate, blood pressure rises. And if this is sustained and frequent for a period of time, this is called our allostatic load. And our theory shows that cumulative discrimination leads to chronic biological stress, increasing allostatic load, and keeps you in a high cortisol state. And the evidence demonstrates that there is an association between allostatic load and a minoritized population group. How do you measure allostatic load? So some direct measures include measuring cortisol levels, blood pressure, heart rate, and insulin resistance, high BMI. But then there are some more direct measures like low levels of good cholesterol, for example. And our bodies also respond to discrimination with epigenetic changes. So what that means in real life is that racism is actually associated with the shortening of the tips of your chromosomes, effectively decreasing your life expectancy, shortening your life. So we know our inputs and processes. What are the health outcomes? So Luna Ali will speak about this in the next presentation. But if we go to the next slide, the main thing I want to highlight is that the effects of discrimination are intergenerational. Minoritized people were bearing this burden even before they were born. Finally, if we go to the next slide, I'll talk about how health systems can be undermined by discrimination. And this infographic taken from our series shows that the evidence again is global. Discrimination undermines how acceptable healthcare is, how available it is in terms of resources, the quality of care that's given. And we know that minoritized health workers, as well as being discriminated against themselves, they can be agents of discrimination. And we also know, finally, that health systems are affected by broader determinants of health, like economics and politics as well. We have massively under-recognized the role of discrimination, and we continue to spend time using sugar-coated language and trying to explain something that's so simple. If we go to the next slide. So a bit about myself. So I was born in Tamil Nadu and I'm of Tamil origin. My family lives in Sri Lanka. It's a country that was colonized 3 times. It suffered a 3-decade-long genocide of Tamil people, and it's currently recovering from an economic collapse. I have seen entire populations being wiped out systematically because of structural racism. And today, 1 child in Gaza is killed every 10 minutes. You don't have to understand complex academic models to understand what is happening right now is that racism and discrimination kills. It really is that simple. But if we can work towards a world, instead of separation and hierarchies being in the middle, instead, if we can center equity and togetherness, that would be groundbreaking, that would be extraordinary, and that would be revolutionary. Thank you very much.
Thank you very much, Abby, and we take note that we've got your website address on screen. I'm sure many people will be interested both in getting your PowerPoint and also going to check more information. I'm going to go straight ahead to our next presenter, and then if we've still got time, I may come back to you, Abby, with a question if that's okay, but we're running a little short of time. What I'd like to do is invite Luna from the European Public Health Alliance to come and share the results of her research looking at the impact of racial discrimination on mental and physical health outcomes for children and adolescents. Luna.
Thank you, Tamsin, and thank you, Abby, also for these incredibly interesting insights. Growing up with a double nationality as both Palestinian and German, I learned from an early age that the way I present myself, my nationalities, and my cultures would profoundly impact how healthcare professionals, as well as societies at large, perceive me. For instance, as a patient, I've encountered situations where my medical concerns were not only assessed based on medical evidence, but viewed through the lens of preconceived stereotypes about my cultural background. Experiences as such are not isolated instances, but a reflection of the systematic biases and inequities that persist within our societies. While many of us in this room are well aware that stereotypes, racism, and discrimination within and outside the healthcare system affect individuals' health, sometimes the precise ways in which they impact health can feel somewhat abstract. Next slide, please. In the last 6 months, I worked on my thesis on the impact of racism and discrimination on child and adolescent health. And when I first started my research, I looked at the numbers of articles I had extracted from my search, and I found myself confronted with an overwhelming total of 3,000 articles, each exploring the impacts of racism and discrimination on physical and mental health outcomes in children and adolescents. And this was a reminder that while the issue is not new, there are still persistent and systematic gaps in addressing racism and discrimination in public health. And these gaps are not only academic or theoretical, but have long and lasting impacts on health outcomes across all life stages and generations. Next slide, please. In fact, racialized and minoritized individuals wear the burden of discrimination even before they are born. As Abby explained so clearly earlier, high allostatic loads of pregnant women can result in poor developmental outcomes in infancy and early childhood. To put this into perspective, this means that, for example, the blood pressure of a child whose mother experienced racism or discrimination during pregnancy is going to be higher than of someone whose mother did not experience discrimination. The impact of racism and discrimination during pregnancy are also reflected in preterm birth rates. As for example, women of African descent in the United States experience preterm birth rates that are around 49% higher than those of white women. And likewise, a report from the UK from 2018 found that compared to their white peers, a Black mother is 5 times more likely to die as a direct result of pregnancy or childbirth. These health outcomes that manifest through the mother's experiences of racism and discrimination in utero already have impacts on the health of the newborn. When we talk about the impacts of racism and discrimination, it is important to keep in mind that diseases don't manifest in isolated life stages, because the effects of racism and discrimination are reflected across the life course and they reinforce each other. If you ask an adult about experiences of racism, the number of times this person will bring up an experience from their childhood is extremely common, which shows how these experiences stick with you. When children become targets of racism, whether through direct personal experiences or by witnessing, for example, their parents being subjected to such treatment, it has well-established and profound effects on their mental health. The majority of studies that explore the impact of racism and discrimination on mental health show that these experiences are linked with higher rates of depression, showing that children who experience racism and discrimination are twice more likely to develop depressive symptoms than children and adolescents who do not experience racial discrimination. Next, please. And racism is inherently stressful, causing stress not only in children who are direct targets, but also in those who observe them, the discriminatory acts. And this chronic stress can trigger the release of hormones in the body over time. These hormonal responses have severe impacts on mental and emotional health. Huge amount of studies also show that children subjected to racism and discrimination are approximately 3 times more likely to show symptoms of anxiety compared to those who have not encountered such discrimination. So actually, children and children who experience racism and discrimination have high rates of anxiety, low self-esteem, and also behavior problems. And other well-established links are between racism and those behavioral problems such as attention deficit hyperactivity, ADHD, ODD, and other conduct disorders. Now that's on the mental health side. Less explored but equally important are the effects of racism and discrimination on physical health. And it is important to recognize that the effects of racism and discrimination are not limited to mental health outcomes. When individuals encounter racism and discrimination, their bodies typically respond by releasing stress hormones such as cortisol or adrenaline. And this stress response, when triggered repeatedly, as often happens in the cases of chronic stress resulting from discrimination, can lead to an overproduction of these stress hormones. The impact of chronic stress, in turn, can lead to disruptions in sleep patterns or the adoption of unhealthy coping mechanisms. For example, several studies showed that youth who report racial discrimination often have less efficient sleep, spent more time in bed awake, and took longer to fall asleep. They also have a high risk of non-communicable diseases such as asthma, obesity, but also NCD risk behavior such as substance use, meaning alcohol use and initiation, as well as marijuana use and smoking. It is so essential to consider this timing of exposure to the stressor because the earlier the exposure occurs during the life course, the more it can affect development and long-term health. And there are terms such as accelerated aging or premature aging that capture evidence that racialized and minoritized groups are literally biologically aging more rapidly than people who do not experience racism and discrimination. So in later life, the effects of cumulative exposure to discrimination interact with the biological effects of age and drive physical and mental health outcomes. And all of this is evidence that our bodies keep a record of all that we have been exposed to over the lifetime. And therefore it is crucial to recognize that racism and discrimination in its structural nature impact health in so many ways across the life course and across generations. Thank you.
Thank you very much. It was extremely helpful to see the overview of everything that you could mention. We're running very tight on time, but we did have one question, so maybe we'll take that one. It was a question to Abby, and I know you also already put an answer in the chat, but Abby, if I could invite you to respond also orally so people here in the room can also share it. Thomas, are you able to tell us what the question was? And then Abby, it would be great if you could answer that.
Of course, there were two questions asked by Isa to start.
Wait, we need to make sure you're on a microphone, otherwise the online audience can't hear us.
I hope I can be heard online. Oh, yeah, sure. Yeah, so I will try to be very brief, but we had two questions from Isa to start from online, and basically to summarize them, the main question about those was there may be certain policies, inclusion policies, health policies in place, or for example, also in the workplace, which are non-discriminatory, but may still indirectly cause inequalities to certain vulnerable groups. And the question to Abby was basically, how is that perceived? How could, for example, health policies anticipate on that?
Thank you. Abby, are you able to respond?
Sure, it's something similar to what I put in the chat, and this kind of goes for all policies that come under the umbrella of diversity and inclusion, which is critical, and it's great to see so much of it, but it's important for us to remember that diversity and inclusion is a precursor to a just society and not an end point. And when we're thinking about diversity and inclusion, when it's done well, it's about minoritized people who are transferred power and being at the center of designing interventions and policies to improve their health in a non-extractive and a non-consultative way. But in our series in the Lancet, we have 6 key principles that actually tell us in terms of how to take action. So I'll signpost people to that.
Excellent. Thank you very much. So can we say a warm thank you to both Abby and to Luna for giving us the results of their research?